Good morning, everybody. I welcome you all to the third Chennai Advanced Wound Care Conference. Today's conference will help us to develop knowledge about advancement in prevention and management of wounds of all etiologies. The knowledge gained could be implemented in advocating highest quality of care. Today we have a lot of international and national faculties to enlighten us. I hope you all will be having an enjoyable and informative session. To chair the first session, I would like to invite Dr. Arun Bal, the founder, Diabetic Foot Society of India. Dr. Bal is also a consultant diabetic foot surgeon and professor at Amrita Institute of Medical Science, Kochi. Thank you, sir. I would now like to request Dr. Srinivas to kindly come to the dais. Dr. Srinivas is consultant podiatric, Apollo Hospital, Hyderabad. Thank you, sir. Now let's begin with our first session. Let's have the pleasure of listening to the opening session by Honorable Director, High Care, Dr. VB Narayanamurthy. Dr. Murthy is an experienced plastic, reconstructive and cosmetic surgeon. He is a senior consultant at Sundaram Medical Foundation and Global Health City. Dr. Murthy is also an adjunct faculty at IIT Chennai. Sir, kindly deliver your talk.
Good morning, everybody, and at the outset, let me thank all the delegates who come from far and wide to attend this conference. I have a couple of announcements to make. We had Dr. Matthias who was supposed to come and talk to us, but unfortunately, I think we had a problem with the visa, so he's not with us today. Aparajita Naka, I think she had some personal commitments, but we do have the opportunity to actually speak to her over Skype. We have made arrangements so that she will still be joining us. Please do enjoy this program. To begin with, what I would like you to say is just give you a brief intro of what wounds are. Most of the things I'm going to say is very basic because we have a mixed crowd here. We have, as you know, that wounds are managed by not only doctors but physiotherapists. We also have the pleasure of having some engineers who have joined us this time first. We also have nurses and other wound care health care specialists who have come in. So with that, let me start off saying, can you have the lights off, please? People who know about cricket, IPL is making all the big news. And as you can see here, this one day I just came in at around 6 o'clock in the evening, and this is what I saw. You can see almost a semi-clad women interviewing fully clad men, and I was quite surprised because there's been a tremendous way things have been changing here. So just want to point out that what's been happening in the management of wounds have also been pretty dramatic in the way in the paradigm shift of thinking. So this is what we'd like to see, what happens in the wound management. The scope of my presentation will be to see how to define wounds, because as we see a wound, we should know, all of us should be talking the same thing. We should know how to define it. Some history. We are proud to say that in India we have the history of managing difficult wounds for a very, very long time. And of course something on wound healing. We also should know what are the various causes. And I can tell you that wounds is a wide spectrum of disorders which we have to keep in mind. It also is different types of wounds, small to very large to complex. Timing of the wound, when we see the wound is very important, and of course where we treat them is important. Some terminology is to be known. Whenever there's an injury, 4 things happen. The body actually tends to reconstruct or repair, which we call as wound healing. We also reconstruct, as you can see here. If something is lost, we try to reconstruct. But 2 things we need to know is there is also what is called regeneration and regrowth. The difference is, in regeneration, the whole organ regenerates. As you can see here, in some of the species, the whole limb can regenerate, and that is modulated by genes, and this is where we are going in the future. So what is the end point in wound healing, if you think? I think experimentally it's been found that if you operate in the womb inside the fetus, then they don't make scars. And therefore any loss is completely restored. There's no scar formation. The wound is fully restored histologically, macroscopically, and also aesthetically. So therefore, we should know what happens. So the research is happening there. Some of the clues we get is that the intrauterine environment is rich in growth factors and so many things, and therefore there is minimal acute inflammatory response, and therefore the scarring is much better. Now coming to definition, it's very simple. Any wound is a break in the continuity of the skin or the mucous membrane. It could be something very, very small, as you can see here. Not actually small, but slightly complex. But sometimes you see there's a very small wound, but is a major wound, as you can see here. The entire limb is actually degloved. So definition of a wound is something where there is a discontinuity of the skin. Now to give you some history, the Pomo Indians are supposed to have said that whenever there's a hole, the person actually goes from living to non-living, and it's been depicted. The famous artist has several times depicted a hole in the body, and to show that whenever there's a hole, they go from living to non-living. And it's not surprising to see sometimes you see worms in the wounds. So why do the wounds happen? There is a huge variety of conditions. I'm not going to the details, but just to say that things from inside and outside can cause damage to the skin, causing wounds. Let's not forget that surgical intervention and hostile environment play a great role in making sure that these wounds don't heal, or they heal properly. So how do the wounds heal? Very, very simply, any wound has a time frame, and this is what we need to look at. At the time of the injury, the initial bleeding happens, and that is controlled. Granulocytes and phagocytes prevent the bacteria from going in, and then they take care of the initial damage. And then the regeneration and the repair process starts on, and finally the wound or the scar is completely remodeled so that you get a very well healed scar. So what is most important to know, that there's an orderly and timely process to produce an anatomical and functional integrity, which proceeds through the process of repair, and more importantly that the sustained result should be there must be an anatomical and a functional result, which means that you should have a wound which is pretty stable, not only anatomically but also sustained physiologically. So when this does not happen, when the normal course of the wound does not follow the normal course, then it becomes stuck in any of those stages, as you can see, and that leads to chronicity, and that causes longer time to heal, and the effect is that there's no anatomical and functional or aesthetic result, and therefore you have a very unstable scar. For example, here, as you can see here, this patient has got a wound, but it is not healed within the time frame of about 10 days to 15 days. So here we should know what is the problem. Either this wound is probably stuck in this stage, and therefore every effort is made by a wound surgeon or a wound care therapist to find out what the cause is and what is wrong and how to deal with it. So I told you the time is important. So we encounter wounds at various time phases, and as you can see here, these wounds are stuck in various time frames, if you like. The normal course of the 14 to 15 days healing period does not happen. That can be because of various reasons. This is the reason. This here, there's no skin, therefore it doesn't heal. Here there is some slough that has to be taken care of. There's infection here, and this, though it's a very good foot with a good blood supply, it does not heal because there's another factor which is preventing it from healing, and that could be because of pressure. So every time you see two things you have to understand. One is the time frame you're looking at the wound, and the second thing, what is the inciting factor which is preventing it from healing. Now, as far as you see the practice of wound is concerned, it also went through some dramatic changes. People are treating wounds for a very long time, and they were treating with a lot of compassion, as you can see here. But the dramatic thing was in the 1964s, George Winter changed the concept from dry wounds to wet wounds. And now we are looking at the advances in genetic and nanotechnology to have another dramatic change in the way we look at wounds. So this is one of the first things to look at. So people were allowing the wound to dry, and then the change was to make sure that the wet wounds are instituted so that the wound heals better. So that brought in a lot of changes. lot of dressing materials and a huge number of things which I'm sure the course of these 2 days you'll be exposed to various materials here, how they are handled, when they should be used to get a good results. The future, I think, will be in the understanding of various growth factors, so that we know how to modulate the wounds if they are stuck in any period of time. The beauty about wound thing is that you can have an experimental model, and therefore we can get enormous amount of knowledge looking at how the wounds happen, keeping the basic wound physiology and the healing in mind. You can actually modulate and then draw inferences. So that is what is happening. So what we had to do is, whenever there's a wound, when you see this is the normal course of events, ultimately you need to have a well-healed epithelialized wound from whatever you see in the previous instances. Now it's also important to know where you treat these wounds. A wound which is very, very simple, as you can see here, may not be as simple, because as you remember that you don't not only look at the wound but also look at the person in whole. So this is a patient who had a very, very small ulcer in the end of the toe, came in septic. As you can see here, this patient was extremely jaundiced. He had liver failure. He was pushed into liver failure with a very, very small infection, and this is what his parameters were. So you have to really look after these patients very well, not only the wound locally but also the patient on the whole. As I told you before, there are other things which can prevent a wound from healing. As you can see here, this wound will never heal unless it's offloaded. And I can tell you that in India, if you give them the total contact casting, they actually abuse it. But still, they go ahead and the wounds actually will heal. So something very simple as a total contact casting in our thing can go a long way to heal very difficult wounds in these patients who cannot afford anything more. Another thing which we can do is, as I told you, if the wound is stuck in this area, as you can see here, if you look at the curve which I showed you, this wound is stuck here. What you could do is make this chronic wound to an acute wound. So you convert a chronic wound into an acute wound, either surgically or otherwise. And then if you can make sure that all the factors which are provided in an acute situation, and making sure that the wound doesn't heal, doesn't actually become chronic, it will go ahead and heal, as you can see here. But again, the problem is, if you don't look after the pressure in these diabetic patients, it will recur. So it is no good if you just do surgically converting a chronic wound to an acute if you don't offload them properly. As I told you here, some of these wounds will not heal because of the problem inside. A simple wound here, there was a chronic tendinitis because of infection, and you remove that, and then 5 days time it will heal. So any wound which does not heal, you have to understand that there is something which is preventing to heal, and that's the whole point of recognizing. An acute and chronic wound, if you can see here, these patients have wounds for a very, very long time. They become acute, and then this wound ultimately has to be treated, and we convert this into an acute wound. So I told you about the causes, the time and complexity, and the place. So what do we do next? There are 3 basic things which we need to do. As I told you, we have to identify, control as best as possible the underlying causes, support the patient-centered concerns like his general condition, and of course do wound care. So always keep in mind, this is the time frame which the wound takes. And then I would like to introduce what I told you before, the concept of moist wound care, which we will dealt with in much more detail later in one of the talks. So how, if we say wound, how do you know how moist the wound is? Very simple. The wound should be moist enough to just keep it moist. What should not happen is you should not allow the surrounding tissues to get macerated, irritated, or get into trouble. So that's a fine line. Clinically, you find out how to keep them under control. So advantages of the moist dressing, as you can see here, it prevents dehydration and cell death. Neutrophils are very important, and a moist dressing will make sure these things are taken care of. It increases angiogenesis. Debridement, which is an important part of management of wound, is protected by keeping it moist. The epithelial cells are reformed, and also it causes decrease in the pain of these patients. Cost, most of them may think that the modern dressings or moist dressings are more expensive, but actually in the long run, if you take into consideration the number of visits they pay to hospital, the number of changes, it works out to be much cheaper in the long run. So an ideal dressing, I'm sure you'll listen to it more, But just to give you an idea, it should be something which will remove the exudates. It should keep the wound moist, allow for gas exchange. There should be thermal insulation. It protects against secondary infection. And again, there should be no trauma when you actually do the dressings the next time. I'm just going to give you a very small video here, which will actually tell you what we do. Can you run the video? It's a small video clip we took for people who are setting up small practices, who wants to do wound care, and also for nurses and other people who are looking after wounds. It's just to give you an idea how to set up a small dressing kit and how to do the dressings. Can you view the video? Just press on that. So basically, the steps are that you should make sure that you have antisepsis, you have cleaning fluids, you have a first layer of the dressings which goes on the wound, which could be a non-adherent dressing. This is the layers where you use for absorption, the gauze, and this is the third layer which you use for retaining the wounds. We also have advanced wound preparations which will actually have very high absorbing capacity, prevent maceration of the skin, and also prevent adhesion of the dressing to the wound. These are very basic things you need. We also have a small dressing kit which should have a small receptacle for collecting the antiseptic, a couple of small tweezers, and some gauze pieces. And when you start doing the dressing, you make sure you clean your hands properly. Take the right amount of antiseptics because you don't want to waste much. Remove the excess and make sure you don't use the antiseptic inside the wound as much as possible. It's very important. You also have another to remove the excess antiseptic, and make sure that you dispose of this thing carefully. Irrigation if necessary, you can use irrigation. Remove the excess moisture, and then you can use the first layer, which is a non-adherent layer here. You can use a non-touch technique just for instruments, or you can use a sterile gloves to use. So this is the first layer, put it in, and then this is to prevent the first layer sticking to the wound, and then these are the conventional dressings which is used to absorb the excess exudation. The third layer is the retaining layer which is used to retain this dressing material. So at the end of it, you have to tell the patient when the next dressing change is to be there, how it should be done, when should they come, and when they come back, make sure that you do the dressings in a way where you're cutting the sutures away from the wound, because patients get very jittery when you take the scissors just in front of the wound. Either you can use the knife or the scissors, and then at the end of the day, you'll have a well-healed wound when you take the dressing off. Just like magic. Thank you. Can you have the last slide, please? Just to summarize, I think it's very important to have a patient-centered approach, because it's very important that you tell the patient what is happening, take him into confidence, and then more importantly, you have to discuss with the relatives, tell them what you're doing, and give them a plan so that he's involved. Ulcer is just not a whole; it's also treatment of the general conditions I told you, and more importantly, it's an interdisciplinary field where you have to have the input of nurses, physiotherapists, nutrition, everything. And more importantly, it has to be evidence based at affordable cost. Thank you very much.
Thank you, sir, for keeping the ball rolling. I think it has been a perfect start for the meeting. He's probably very crisply told all of us on what we're going to do the whole day today and tomorrow. So I think if the audience have one or two quick questions for Dr. Narayan Murthy.
Do you routinely use hydrogen peroxide?
If you have a wound which is very dirty, if you have a lot of let's say pus and then blood in the wound, I wouldn't say it's a good debriding agent, but it's a good cleaning agent. So I do use them fairly regularly, more so to clean the surrounding of the skin. If there's blood splashed, we use them.
For a wound, you should have a clear wound. For that, how many days dressing you advise?
Now,
Clear wound, the one you showed.
see, as I told you, first define the wound. If it is a clear wound with no infection, if it is granulating wound, then what you have to do is, if the wound is very large, you may have to do a graft. Otherwise, if it's a small wound, you have to encourage the wound to either epithelize or to heal by scar tissue. And the most important thing is you have to see how the wound progresses. If the change of dressings will actually happen depending on the amount of exudation. So if the wound gets very wet and dirty, then you may have to change it. If the wound doesn't get wet, you can actually leave it for about 3 to 4 days. If you use advanced wound dressing materials, you can actually reduce the number of dressings because they will actually make sure the exudation is taken care of. It's not very messy, and the wound can be kept as moist as possible as is required. So the answer to your question depends on evaluation every day, defining the wound, and seeing the amount of exudation, and then change, and types of dressing material you use.
Thank you, sir. Does the lady have any question? The last question for.
Use of povidone iodine dressings. How far we have to proceed with this? Because there are so many studies related to that use of povidone and chlorhexidine.
The use of povidone iodine on the wound, I don't regularly use them.
Okay, sir.
The important thing is if there is slough or if there's any infection, you had to debride, and then povidone iodine you don't have to use them on the wound. So it's a good antiseptic solution to clean the surrounding wound, and then sometimes I think orthopedic surgeons use quite a lot for irrigating even normal wounds. I don't think it makes much of a difference. Sometimes it can actually do more harm. So the verdict is very difficult. So you can or you cannot, but I normally don't use.
Thank you, sir. And I think we had a fruitful discussion. For the second session,